and try to provide the learners with a clear basic concept and explain the simple reasons behind every clinical step.
These guided sessions also prepares us for those questions which are asked in our Viva and furthermore other limitless questions that can arise anytime during our clinical practices.
We believe our sessions can establish a bond between the learners and the presenters and also encourage our learners to come forward and step up for presenting on various topics as it will open doors to limitless benefits.
So, join us in studying together as a team and help us to raise this platform to the next level. Journey to be the better doctors, the Grey Medicos. Thank you very much.
Hello, Namaste, and good afternoon. Welcome to this webinar. I am Sushil Thakal, host for the today's program. Currently a fourth year medical student at Universal College of Medical Sciences. As grey is the color that lies in the transition of black and white, we medical students are in the transition of knowing nothing to knowing something. Hence, the name Grey Medicos was given. Before starting today's program, let me highlight some of the ground rules. Everyone must come up with their real names. Fake ID will be removed instantly. Chat box will be disabled. Queries will be taken at the end of the meeting. Let me highlight today's topic is fracture and its complication. Without further ado, I would like to welcome mentor for today's program, Dr. Kishore Man Shrestha sir, Associate Professor at Department of Orthopedics at Universal College of Medical Sciences. Welcome, sir. Talking about Dr.
Thank you.
Thank you so much, sir. Dr. Kishore Man Shrestha sir is a humble and inspiring person. We are so blessed to have you in our program, sir. Thank you so much. Now, let me introduce the presenter for today's program, Mr. Ravi Basyal, a fourth year medical student at Universal College of Medical Sciences. He is hardworking person. Now, without further ado, I would like to give this virtual platform to the presenter of today's program, Ravi Basyal. Ravi, the virtual platform is all yours. Thank you.
Hello, everyone. Good afternoon, sir. May I begin, sir?
Yeah, sure.
Okay, sir. Is screen visible?
Yeah.
Okay, sir. Mr. X, 18-year-old male from Borgat, student, Hindu religion, unmarried, was admitted to UCMSTS emergency with chief complaint of pain in right leg since 1 hour, pain in bilateral end since 1 hour following a road traffic accident. In history of presenting illness, my patient was apparently well 16 days back. He had collision with a scooter with sustained injury overhead, bilateral hand and at right leg. Pain was in right leg, acute in onset, continuous in character, non-radiating, aggravated on movement. Pain was also at bilateral end, acute on onset, continuous, non-radiating, aggravated on movement, and pain was severe. He also had injury overhead and mild abrasion over bilateral head. He has history of loss of consciousness for about 1 hour. No history of bleeding from ear, nose, and mouth. No history of abnormal body movement. No history of vomiting. No history of urinary retention. He was operated and today is second post-operative day. In my past history, no history of similar illness in the past. No history of chronic disease like TB, asthma, and hypertension. In personal history, he has no history of smoking and alcohol intake. He consumed mixed diet. In family history, no history of chronic disease in the family. In drug and allergic history, no known history of drug and allergic history to food. In a general survey, my patient is lying supine on position, conscious, well oriented to time, place, and person. Average build, thin cannula on left hand. Thin build and thin average build and cannula on left hand.
Typing mistake.
Yes, sir. No pallor, no icterus, no palpable lymph node, no coilonegia, and no cyanosis, no clogging, no edema, well hydrated. On the systemic examination, on CNS examination, eye response was 4, verbal response was 5, and motor response was 6. And in CVS examination, S1, S2 was heard, and there was no murmur. On respiratory examination, we found that not normal vesicular sound was heard. For abdomen, soft, non-tender, no palpable organomegaly, no palpable organ. On local examination, on inspection, I found that a right leg was elevated above the pillow. Slab is placed above knee, posterior slab to neck of metatarsal. A right lower limb flexed at hip, at knee, and ankle was neutral. On feel, tenderness present above proximal leg. At proximal leg, and movement on right. Movement was restricted at knee joint due to slab. On left leg, normal movement at hip, knee, and ankle joint. On DNPS, distal neurovascular system examination, capillary refilling time was less than 3 seconds, and dorsalis peris artery was palpable, and sensation over first wavy space and dorsum of lateral aspect of foot intact. With this, I have completed my history, sir.
Wait for a minute. First, you go to the chief complaint in the first slide.
Okay, sir.
So in this is Mr. X,
Yes,
18 years male from Barga student, who was admitted to UCMS emergency 16 days back. You have to write a 16 days back. You have already 1 hour. In history of presence is only 16 days back.
Yes, sir.
Yeah. So, 16 days back, admitted in the UCMS emergency with the complaint of this for 1 hour. Yeah. The second slide. So you are the appointment with 16 days back. Okay.
Yes, sir.
So you have to mention the 16 days earlier also. Hello?
Yes, please.
Yeah. So we can go to the last slide.
May
In summary.
yes, sir.
Yeah. In summary also you have to mention the 16 days. I forgot.
Okay, sir.
And there is also typing mistake, I think so. There is a here's Mr. X, 18 years old, president 16 days back with in the emergency with the chief complaint of pain in right leg and bilateral hand following RTA, which was acute on onset and aggravated by the movement. Okay. And for this, he was operated twice. I think he was operated twice. Okay.
Yes, sir.
Yeah, he was operated twice. And the second operation, now today is the second day of second operation.
Yes, sir.
Okay. with this history and with this history and clinical examination, so you have to find out what is the provisional diagnosis. What do you in the mind? What comes in your mind? What may be the diagnosis?
So my diagnosis might be proximal tibia fracture, sir.
No, you can't say proximal tibia fracture. So you have to give the reason why.
There was pain at proximal tibia, sir. So and
So you have to say with this history and clinical examination, as he has a history, he have pain, okay, pain over the right leg and bilateral hand. We are escaping hand, okay. We are only
yes,
focusing on the hand, okay. We are only focusing on the right leg, okay. So with this history and clinical examination, since the pain started after the road traffic accident, so there might be something, either means soft tissue injury or fracture over the right leg. Okay.
yes, sir.
So there might be first, you have to be, there may be a fracture. Okay, fracture over the leg. That may be tibia or fibula. Don't say specifically proximal tibia.
Okay, sir.
That means that it will say that means you have already seen the diagnosis, or somebody's your friends or your seniors have figure that already told that you are already known to him. This is this case. Okay, you should pretend that you know nothing about him, the patient. Okay, or there may be a fracture over the leg, either tibia or fibula, anywhere, and there may be a soft tissue injury over there. Okay, so for confirmation, what you will do?
So for confirmation, I will send the X-ray, sir.
X-ray. Okay, X-ray of what?
X-ray of right leg uh, and in anterior posterior view and lateral view.
Okay, you have to send the X-ray in two views. Okay, and
Yes, sir.
there is only whenever you are uh, writing for X-ray, you must know the rule of two. One is two views. Okay, minimum two views. Okay? One is anterior posterior, other is lateral. Yeah, and other is the
Yes, sir.
second rule is other is the two joints, including two joints, including you have to write X-ray of right leg, anterior posterior and lateral view, including what are the two joints of the leg? Upper knee
The,
and
sir,
ankle
there
joint,
are knee joint and the ankle
and
joint.
below is ankle joint. So you have to write X-ray of right leg, anterior posterior and lateral view, including knee and ankle joint. You have to write clearly. Okay. So you have seen the X-ray, yeah. So
Sir.
what does it seem? It looks like. Next slide. Maybe in the next
It's
slide.
look like yes, sir.
Maybe in the next slide.
Yes, sir.
So this is X-ray of right leg. So what is that? What is over there? So it is a good
There is
X-ray?
fracture.
It is not a good X-ray. Why? Because there is no two joints.
Yes, sir.
There is no knee joint. Okay. Ideally, it should be two joints. Okay. Okay. So what do you see on the X-ray?
You can see there is on the proximal tibia there is fracture, sir.
No, you have to,
Cognitive fracture would be
no, you have to describe systematically the X-ray.
Yes, sir.
So this is the plain X-ray.
It's the plain X-ray of uh, right leg.
So there is one, there is some, there is cut of this R, means it's right. You can't say with only the plain X-ray with right, this either is right or left. This R, so marker this R. So use the right leg, okay? Right leg showing
Showing right leg, showing a fracture over the
no, you have to
proximal
say
tibia of the
no.
right leg.
Sorry to disturb you. Yes, you should explain it serially, okay? This is the X-ray of right leg
Yes.
showing this big one is almost all tibia, yeah, and this small one is fibula, ankle joint, and part of talus. Yeah, so you have to write this like this way. Okay, then either you have to go from inside to out or outside to in, just like in medicine you describe the chest X-ray. So there is a fracture, which is there is a breach in continuity over the proximal part of tibia, and there are multiple pieces. This is communicated. Do you get me?
Yes, sir.
This is a communicated proximal tibia fracture. Any question for this?
No, sir.
So there is a comminuted fracture of proximal tibia. After seeing the X-ray, you then know that, oh, there is a combination. There is a big tibia fracture, proximal tibia. So in your mind, what comes in then? Because
This
you
is,
have you could not see the wound part, so there is either open or closed. You couldn't know. Okay, for this time,
yes,
for
sir.
this case, there might be open or closed. Right? Okay, for this severe fracture, severe comminuted fracture, what might be complication you think? The important complication that might occur, you suspect.
There might be open fracture, sir.
Okay, there's the open fracture. That this okay. Another by seeing only this X-ray only, because there is a severe. There is combination. The injury is severe. Yes.
Yes,
And
there
in
might be bleeding,
proximal.
sir.
Okay. Okay. Next important complication.
There might be fat embolism.
Okay. It's really on the tibia. It's more on femur. Another important.
Yes.
Okay, since
There
this
might
is
be
proximal,
compartment syndrome, sir.
yeah, you must not forget the compartment. So, okay, the patient may go into the compartment syndrome. Why?
Because the pressure inside that osteofacial compartment may rise and that may compress
Because yeah,
that
because
may compress vessels and that.
okay, because it is a proximal tibia. Yeah, there are group of muscle. Okay, there are more muscle over proximal tibia than distal tibia. Yes or no? Muscle belly.
Yes, sir.
Yeah, in lower tibia that have already gone into, most of them muscle have gone changes into tendon. Yeah, in proximal tibia there are more muscle
Yes,
belly, so there may be a, since there is a huge injury, there may be chances of swelling, so may go into, pressure may rise, may go into compartment syndrome. So that's why the first operation is there for the X-ray, first operation X-ray.
Yes, sir.
After first reference.
Yes, sir. There it is.
So this the left hand one was, so that's why external fixator was kept. As there is a puncture wound, so get type 1 Gustula Anderson type 1, and the patient may go into the compound zone. So to reduce the swelling and for dressing, we have used the external fixator. Till the skin condition is normal, the patient may go into the compound zone to have applied the external fixator, and also for dressing also. Okay. Then after the you know you have to see clinically, so we cannot comment in the X-ray. Okay. Then after the swelling subside and the wound gets sealed, then we have changes the external fixator into internal fixator. The next one, the next picture. Yeah, this is the plate and with treated by plate and screw. Okay. So this is the manner we have done. First, after the you have diagnosed the fact there is a fracture, how will you manage that one? When the patient comes with this patient in the emergency, how do
Yes,
you
sir.
manage the case?
Initially, when the patient comes over to the emergency department,
Mhm.
initially I will check for ABC, airway breathing and circulation,
So you
and
manage according to ATLS, Advanced Trauma Life Support Protocol, ABC, like okay. Then
yes, and after that, clearing all the airway and approaching towards breathing and circulation, I will
so
be moving forward for yes, sir.
say continue.
Then after then I will be looking for either it is open fracture or closed fracture,
Yeah.
and if it is closed fracture, then I will uh, go for slab, sir, and
Mhm. So no, you have to
I will
diagnose. First, you have to recognize and you have to diagnose there is a fracture or not. You have to send the X-ray. Okay.
yes, sir.
Then you have to.
And then if manage the pain as well, sir. And after
I mean,
managing the pain, I will send the X-ray,
mhm.
and if the after X-ray, I will be looking for
So how do
where
you?
the fracture is.
Okay. How do you manage for the pain?
Pain I will be giving, sir. If the patient is drowsy, then I will not give him the narcotic drug. If he is conscious, then I will be giving to narcotic or
To minimize the pain. Okay. So to minimize the pain,
yes, sir.
first you have to give the painkiller. Okay. Painkiller along with
Yes, sir.
you have to immobilize it by any means, splinting or any local means. Okay, you have to immobilize so that the fracture part doesn't move, the limb doesn't move. Okay, by any means, either that might be either wood or stick or slab, anything. Okay, along with the anesthesis. So by this way, you have to reduce the pain. Okay, then
Yes, sir. And then after pain management, then I will be looking for X-ray, sir.
uh,
If there is after X-ray, we can diagnose the fracture, and then uh, and according to fracture, then we will be moving
treated.
forward
Okay,
for the treatment approach.
treatment. Okay,
Yes, sir.
for this patient, we have done the because we have there is since this grade type 1 uh, open fracture and there is severe combination and there is huge swelling, so we are temporarily fixed with the external fixator. Okay,
Yes,
right?
sir.
Immobilize the fracture. Okay, with temporary fixator. Then after the skin condition, then we retention of the fracture with the we have done with interfere with this is the plate and screws.
Yes, sir.
Okay, so most these are the any questions regarding this?
No, sir.
No, sir. Because and one thing in this case, we have already given the antibiotics because it is a type 1 type 1 Gusti Anderson open. We have already washed the wound, manage for the wound. Side by side, we have to also manage for the wound, giving the cleaning, debridement of the wound, and external fixture till the skin gets good, wound gets good. Okay.
Yes, sir.
So with this one case, we have studied. We have known that now you have known that how to manage the fracture, how to recognize the fracture. Okay, what is the process of the management? Process of
Yes,
the
sir.
treatment of the fracture, and we have listed some complications. Okay, and what may be the other complications? Since this is a type 1 open fracture, what may be the complication? Other complication? One is compartmentation, or you have said since it is open, it may go. If you haven't treated the wound clearly, it might go for infection. So it may change into the acute osteomyelitis and later on chronic osteomyelitis.
Yes.
Yeah. So तिम्रो क्लास त अझै आउँदैछ होला हैन अझै still
Yes, sir.
it will come in later by later, side by side. So any question? यति नै हो कि अरू पनि छ?
That's all right. To rule out the chest trauma or chest anything, so we have taken for the X-ray, and there was paired bilateral limb, so we have seen the X-ray of the ends, bilateral end, and there was history of loss of consciousness as well, so we have seen the CT scan.
And neurosurgery consultation.
Yes, sir.
Okay. Any questions?
I think there is question from
Ravi?
yes.
Yeah, I want to ask you one thing. What you will do to prevent any infection for such fracture in emergency? Step-wise, can you elaborate all the steps that you will adopt in emergency to prevent such infections in emergency?
Emergency, and then initially I will be cleaning the wound with the normal saline, and
Yes.
And then I will be proceeding towards the either it is open or closed, and if it is closed, then I will classify according to Gostatilo and Anderson classification, and then I will be moving.
You haven't understand the question clearly. Okay, he's saying that for open, this is the open fracture.
Gostatilo Anderson.
When type 1 open fracture, the patient is already come to you. What you will do in emergency department? So okay, you have was, and first you have to give the prophylactic antibiotics.
Yes.
To cover all the organism, gram negative, gram positive.
Yes, sir.
and anaerobic organisms. But you have to cover three organisms by triple antibiotics, then wash or debride. Wash thoroughly with normal
Yes,
saline.
Yes.
yes, sir. Yes, sir. Thank you, sir.
Welcome.
Okay, over to you, Ravi.
Thank you, Dai. And then, sir, we will be moving after giving antibiotic. Then we will be looking for.
Hello.
Yes, sir.
Uh,
So I will be if the case is open fracture, then I will be approach the case, sir.
so you have to first you have to give prophylactic antibiotics. Okay,
Yes,
IV antibiotics. Then you in emergency you wash thoroughly. Okay. Then
yes, sir.
for wound management, you have to see either you have to splint it either by slab or X-fix, external fixator, so that you could do dressing. And side by side, you have to give the antibiotics also till the wound gets better. Okay, and once the wound gets better and slowly subside, then you can change the external fixator into internal fixator, like we have done in this case. Hello?
Yes, sir. Yes, sir.
Yeah.
Okay, sir. Thank you, sir. I think I have completed my presentation, sir.
Treatment part also gone. We have already completed up to this.
Yes, sir.
So, okay, another question is, my question is, if you suspect, okay, we have prophylactic applied the external fixture in this for open fracture and to prevent the swelling also, further swelling also. Yeah. So, if you suspect compartment syndrome,
Yes, sir.
okay, how you would suspect the compartment syndrome in this case?
With
In
the
what
clinical features, sir.
in what is the important clinical for the compartment syndrome?
Normally there are 6 features, sir. They are pain, paresthesia, pulselessness,
Okay, which
and
one is the important one?
uh, by pain and the pulselessness, sir.
No, it's pain out of, not only pain out of proportion. Okay,
Yes,
for
sir.
this type of, if the patient is crying out a lot, okay, he's feeling pain a lot for simple health, so you should suspect compartment syndrome.
Compartment.
Okay, not the pulse. There might be presence of pulse also. Maybe fever, there may be presence of pulse. You should not wait till the pulseless. It will already gone. It will be already dead over there. Okay, so
Yes.
if you suspect compartment syndrome, what you will do?
Uh,
So
if there
he
is any
in the
cast, then
swab.
I will.
Okay. Ah,
Yes, sir.
sorry, if you say.
If there is any cast, then immediately I will remove the cast, sir.
Okay, you have to release the factors causing the compartment. So that there may be a tight cast or tight dressings. You have to release that one. If again still
Yes,
it's
sir.
not working, then what you will do?
And then I will elevate limb to level of what?
Mhm.
If there is any hypoxia, I will correct that, and I will correct any hypotension. And then if there is hypoxia, then I will be giving him supplement oxygen, and then
Oh, no,
I
no, no.
will do the
This
immediately.
so you are this the other one. And so for the limb,
Yes, sir.
I'm saying talking about the limb.
I will be doing the osteofasciatomy, sir.
Not osteopathy, it's a dermofasciatomy or fasciatomy. Okay, dermofasciatomy means skin and fascia you have to release. Means you have to open the closed compartment, osteofacial compartment. Okay.
Yes, sir.
Yeah. This, you can say dermatofasciotomy or fasciotomy. You have to do fasciotomy.
Yes, sir.
Is clear till now?
Yes, sir.
Any questions, other?
I think there is no question, sir. Cecil, is there any question?
No, Ravi, there are no any questions.
I have completed my presentation here.
Okay, so
Thank
it was a wonderful discussion. It was a very fruitful discussion, sir. So we got to learn a lot of things. And thank you so much, sir. We will also like to acknowledge the presence of our Dai, Dr. Budhraj Dai. Thank you so much, Dai, for being in the program. Now, I'd like to request Ansel to present token of love to our mentor for today's program, Dr. Kishore Manshrestha, sir. Ravi, can you end the slideshow?
Okay, okay.
Thank you.
Thank you.
Sir, we'd like to hear a few words from you, sir, about today's program.
It's a very nice program. It's a very nice and unique program. It's initiated by you all. It will be I think it will be a great platform to learn new. Still, there's learning is never ending. Oh. Okay, you can learn from anybody. So it might be you. Maybe I can learn something from you also. You guys also. It's a never ending learning. Okay, you have still try it. It is a first step. I think it's the initial step in your orthopedics. I think there is a lot to. There is also always room for improvement. And in later days, I think you will improve a lot.
Thank you so much, sir.
Okay, thank you.
Thank you so much, sir. We'd like to hear a few words from our Dr. Budhraj Dai as well. Dai, are you there?
Yes, yes. Yes, first of all, I'd like to congratulate you guys. You guys has absolutely presented well. Thank you, Kishore sir, for your wonderful advices in all the history along with the examination part, and the most important is the investigation part. Sir has already focused about the involvement of the two joint, two views. That is the must for orthopedics, and overall the management of the fracture also has been explained well. The indication of external fixation for this case and about the internal fixation. That's all. Nice presentation. Hope you guys will do more presentation in the coming future. And thank you, Kishore sir.
Welcome.
Thank you so much, Dai. Now I would like to request Ansel to give our Thanksgiving speech. Ansel, are you there?
So, hello and good evening, everyone. On behalf of the entire team of the Grey Medicos, I would like to extend a heartfelt gratitude to our mentor for today, Dr. Kishore Man Shrestha from UCMS Bhairava, for taking out his time despite his busy schedule on a holiday to teach undergraduate students like us. And it has been an extreme honor and pleasure having you with us, sir. And we hope to hear from you in future as well. And I also thank Mr. Robbie Bashial for a good presentation. And with this, I would like to hand over the floor to the host. Thank you.
Thank you so much, Achal. Now we are at the end of the meeting, so I would like to request our host to end the meeting. Thank you so much.
Thank you.
Thank you, sir.
Thank you.